Oh, okay, that's good. So Dr. Zico W. Mianyen, a Liberian, hail from Nema County. And I have a Bachelor of Science degree in biology and chemistry. And I also have a doctorate in medicine. I graduated from the Achilles Mario Doklati College of Medicine in Liberia. I'm currently practicing medicine. I've had 3 years of experience in the field of medicine, and I work with a variety of consultants, and I'm a general practitioner, and I really, really love the field of medicine, and I think it was a good decision to be a doctor. And also, it's a pleasure to be on a platform to be one of the panelists to discuss your related topic. Thank you.
Ladies and gentlemen, if you are just joining us, this is Focus on Liberia. We are discussing chronic diseases, their signs, symptoms, treatment, management, and prevention. With me to discuss this, as you heard him, Dr. Zico Mianyen, who's joining us from Monrovia. We also have Abby Tyler and Eva Sahr, who are joining us here from the United States. So let's go again to Abby to just a little bit about yourself.
Hi, my name is Abigail Tyler. You guys know me as Abby Tyler on Facebook. I am a registered nurse, PSN. I have been a nurse for 22 years with experience in long-term care and home care. I am a certified registered nurse preceptor, certified nursing assistant instructor in the state of Pennsylvania. For the past 20 years, I have worked as a cardiac nurse on the telemetry floor, which is like step-down ICU. And I also conduct health fairs for my local Liberian association. And I run a health blog on Facebook called Abby Tyler's Healthy Living. So if any of you want to join, please send a request. And I'm happy to be here to be of assistance.
Thank you, Abby. Let's hear from Eva Sahr, who's joining us from Virginia.
Hi, everyone. Thanks for having me on the show. I work in healthcare administration. I've been doing healthcare administration for over 15 years. I have my MBA with a minor in healthcare management. And I'm just here to share my experience about my personal health. And I'm also part of a group on Facebook. It's called Liberia's Biggest Losers, and we'll talk a little bit about it and what we're trying to do, especially with our community and being healthy and also helping out the community in other ways.
Thank you, Eva. So our topic today are chronic diseases, and some of the chronic diseases we'll be talking about hypertension, heart disease, stroke, diabetes, kidney disease, cancer. And if we have time, we can delve into more. But let's start by saying, by the definition. What are chronic diseases? And this will go to, and any of you can pick it up. Or let's have this as a discussion, so you can just share knowledge. So, Doc, let's start with you.
From my end.
Any one of you can go first. So go first, Doc.
I think the nurse can start the ball rolling,
okay.
Then I will conclude.
All right.
Okay, before we start that, let me just take a few minutes to just give a little quick update on the coronavirus, since it is the most pressing issue right now that we have in America and around the world. I just want to let you guys know that coronavirus is very real. I know people are saying it's just for the elderly people and for people with pre-existing conditions. It is also affecting people without pre-existing conditions. And those of us who don't have any symptoms will also spreading it out. So please, 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 I implore you, please stay home. Follow your local advice there, your health department or your federal state. They tell you to stay home. Please stay home. Only go out for normal things. When you guys come to the hospital, just remember, we're the ones that are taking care of you. We also have chronic diseases, and you're putting our lives at risk every time we have to take care of you. Yes, we're going to do what we were trained to do, and we've been paid to do. We're giving up our lives and our safety in order to take care of you. So please, If they're telling you to stay home, please stay home. And people are saying, oh, the news media is sensationalizing it. Yes, the news media does do that sometimes, but it hasn't gone down yet. Please take it. It's very, very real. And most of these people who are very sick, until you see it firsthand, they're dying alone. No family member. Nobody's allowed to come and visit. You only see your family member way after. And that is so sad. So please just take our advice and just stay home and follow the instructions that's being told to you by your local and state and federal officials. And hopefully the longer, as long as we're complying with all that, this will be over hopefully soon. So just please, like Rimpo said, bear patient, okay? This is very serious. Coronavirus is no joke. Please, please, please. Okay,
thank you, Abby, and it was very important. Good that you brought that up. So we're gonna go around the room, just to give a little update on what we need to do so as to prevent this disease, or to stop it from this kind of spread, which is unprecedented. I've never seen anything like this. So just a little, from me personally, we are indoors. I was just at Walmart, and that's the farthest I've gone in 2 or 3 days, because we needed to get some snacks. So, and I have my mask on and all that. So let's go over, and we start with you again, Abby, on what we need to do as precaution. What are some of the signs that people to look for, and what we do? And then we'll go to Dr. Mianyen from Liberia. What really is he telling his patients to do as to stop the spread of the coronavirus?
Well, if you're not an essential worker, stay home. Like they're telling you, stay home. When you're staying home, make sure you're washing your hands as much as possible. And until you stay home with the people who you live with. Not go out there and go hang out with the other people, or go out to play basketball. We've been seeing a lot of that in the news. Stay home with the people. If you're going to go walk out, stay with those people that you live with, because everything is right within there. So if you guys are healthy within your little circle, you're going to remain healthy within your little circle. Go out as much as possible, as little as possible, for the things that you absolutely need to go out for. Wash your hands while you're there. Have your hand sanitizers. Women, take a little purse. Don't take your whole pocketbook where you have to keep looking in to get stuff out. Clean your purse when you come back home. Men, clean your wallet. If you have to sign anything, any credit card stuff at the store, make sure you take your own pen with you. And I think most of the hand sanitizer, if you don't have your pen with you, make sure you just wipe. There's hand sanitizer available now everywhere. Wipe your hands. You come back home, spray all the surfaces. Make sure you keep yourself hydrated. Watch out for any kind of prolonged fever. Watch out for dry cough, sore throat, and everything, and headaches. If you find yourself laying around and you don't have enough energy to move around, call your doctor, explain the situation to your doctor, and your doctor can determine whether you need to go to get tested. And they have other places beside the emergency room. So please don't just go to the emergency room because you're scared. Because like I said before, you're going to be in a room with a whole lot of other people who are there for many other reasons. And if you're there and somebody has a stroke, or somebody came there with chest pain, they're going to take care of those people first. So you're going to be sitting there for a while waiting and breathing it, and also infecting other people if you happen to have the virus. So please take care of yourself and take care of each other, and keep an eye out for your older people. Don't visit them too much if you don't have to, but just please call and just make sure they're fine. That's just like a brief thing of what I have to say now, instead of going too long into it.
Eva, what's going on at your hospital? What's the protocol, and what you want us to take a look at? Anything that Abby left out that you want to piggyback on or add?
Well, I haven't been to work for the past week because I was exposed by one of the doctors. So I'm home quarantined for 14 days. I got tested, so I'm just waiting for their test results. I don't have any symptoms, but I'm just praying. You don't know. Coronavirus does not have a look. It does not have a, especially in the beginning, you look at somebody you wouldn't know, because, it can be asymptomatic for a while. So just like they said, stay home as much as you can. I know, some people, essential workers, it's hard for us to stay home. And, it's can be get anxiety and things like that. You just have to find a way to see how you can handle it, or how you can cope with it. Just keep a clear head so you don't make any mistakes that could expose you. Wear your protective, your PPEs wherever you can, and just follow all the different protocols from CDC. And sometimes use your common sense. That's one of the main things I think sometimes we forget. Use our common sense.
Dr. Mianyen, we in the United States, we have a way of kind of protecting ourselves. I was at Walmart shopping, and I cover myself up because it's allergy, a lot of pollens in the air. So I inhale that, and then. But in Liberia, the things we are able to do here in Liberia, I mean, you just can't. I mean, you have to get out. You have to do stuff. So I know it's the protocols in Liberia may be different. What are you telling your patients to do?
For now in Liberia, and as a team leader in the clinical setting, we have the responsibility to give the public health message, the preventive message, and we also have the responsibility to talk to our nurses, nurse aides, and clinicians to also be careful from the clinical standpoint. So with the public health message we give our clients, our citizens, and people of Liberia is that, the difficult issue about this entire COVID-19 is it has to do with involving literature. New information keep coming. So as the information comes, we have the responsibility to read every night and be on top of our games, because literature will say, this is airborne, it doesn't stay low in the air, and at a certain time it will come down and what have you. Using masks is important, it's good, and also constant hand washing is also good, but we also advise our clients, our citizens, to avoid touching orifices like the mouth, the nose, the eye, the ear, because we can't tell. Literature, we don't have 100% literature on this dirty virus as compared to Ebola. For Ebola, we have enough literature and we knew how to handle it. So you can't stick to just the little literature you have. You need to spread your knowledge and make sure you keen to the ability that you can't allow the viruses to enter any of the opening. So stick to washing hands. And for us, our clients, they may not afford hand sanitizer. So if you have soap is enough. Use a soap more frequent you can. If you can use a soap like every 5 minutes or every 30 minutes or every 1 hour, make sure to encourage our clients to use a soap, and make sure to avoid touching your nose, your eyes. When you sneezing, if we don't have masks, like in our time in Liberia, not having masks, you can sneeze in your elbow or sneeze while you cover your mouth using your shite. Okay, to avoid predisposing your relative or family members to the deadly disease. Because we're not praying for anybody to come down with the coronavirus, but we can't tell. If one person has in the family, it's better you stick to the rules, then you can avoid it. Because waiting for fever, waiting for sneezing, waiting for coughing, waiting for pharyngitis and other stuff, you may not have those symptoms. Because for us in Liberia, as health practitioners, we're still wondering. Because our third case, up to now, we can't trace where the third case contacted anybody with coronavirus. The first person we thought that the person may have been the possible candidate of giving this virus to the third case. Up to now, we did a test for the person from Italy, and the person is negative. So this is a challenging pandemic, a very challenging pandemic that nobody has 100% monopoly over how it spread, how it can be controlled. So the best we can do for our clients to always tell them to have the distance. Social distance is also important, and make sure you use a soap, use a soap. And from the clinical end, clinicians, don't overlook any respiratory symptom. All right? Don't say, oh, this time around we're in a dry season, somebody's sneezing is a normal phenomenon. No. Make sure to think coronavirus first until otherwise order. Make sure to protect yourself. And in outbreak, there is no emergency. In an outbreak, there is no emergency. If you have a bleeding patient or somebody in respiratory distress, we love the job. We agree we need to rush on the patient to stabilize the patient. But make sure you are protected. Make sure you have your full PPE. Because if you are not full PPE, at the end of the day, you may lose your life, and hundreds of clients you're supposed to treat in the future, they may not have you to treat them. So there is no emergency in outbreak for our clinicians. For our clients, use your soap, social distance, use masks, cover your mouth, cover your nose when you're sneezing. These are messages we make sure to give to our people so that we can curtail this deadly disease. But from our end, we give God the glory. Since our 3 cases, we are on our feet in showing that we shouldn't exceed the 3. And I think by God's grace, and God come first, okay? By God's grace, we will overcome this entire coronavirus outbreak.
Thank you, Doc. And that's the message on the coronavirus. And we hope all of you listening can take heed and just share the message. So now back to chronic diseases, our topic for the day. So Abby, let me start with you. Define for us what are chronic diseases and what are some of the major ones that we're going to be talking about today.
Well, chronic disease is usually described as any kind of disease, any kind of illness that persists from 3 to 6 months. Let's say you were having heartburn and you call the doctor, or you take over-the-counter medicine and it goes away. If it continues to come back over a period of time, when you go to the doctor is going to ask you, well, how long have you been having it? What have you been taking for it? What has worked? What has aggravated it? They're going to ask you all those questions. And if it's about 3 to 6 months, depending on the disease now, not if you're having chest pain or stuff like that. And the doctor will tell you, okay, this is when we're going to do some testing. And then based on the findings and all that, that will be considered chronic. Now, there are many other different definitions and all that too. I'm not going to get too clinical and say, yeah, but usually between 3 to 6 months, if the symptoms have persisted for that long and after diagnosis, then they can consider that like chronic disease. And based on your lab values, your x-ray, anything that's applicable to diagnosing that disease. Some of the major ones that I did talk about on my forum also, the major ones that affect mostly Black people. Well, Black people are like always like higher risk of getting just about every major disease, but you can talk about hypertension, which is also called high blood pressure, diabetes, high cholesterol. All those diseases lead to kidney disease as well, and also cerebral vascular accident is also called stroke. So those 3 major diseases, I actually kind of listed 3 or 4, but 3 major ones: the stroke, heart attack, chest pain, high blood pressure, kidney disease, and diabetes are the major ones that we look after because they kind of lead to other diseases.
Eva, what's your...
And also, if you add cancer and other things into that, so for women will be breast cancer, ovarian cancer, any other gynecological cancer, and for men, prostate cancer, which affects Black men more than other races.
Eva, what's your experience?
Well, I don't have any of these, but
yeah,
I've been close to getting diabetes. Diabetes runs in my family, and high blood pressure. I can say just about everybody in the family has it. Aunts, uncles, grandparents. My maternal grandmother passed away due to complications of diabetes. I think back home and high blood pressure, those are the 2 biggest that we have. I have someone close to me that's dealing with, colorectal cancer. That's one of the main ones also. I personally, every year I go get tested, especially for diabetes because it runs in the family. And 2 years ago, I was tested and they told me I was, borderline diabetic. So that's when I decided I need to stop doing certain things, which we'll probably talk about in later shows. But I just knew that I had to turn that completely around and turn it back before it turns into, full diabetes. So I've been working on that. Yes.
Yeah. So chronic diseases, first of all, the word chronic. Chronicity, most often patients consider chronicity to be like severity, like this is desperate, this is so hard. So chronicity has to do with duration. So chronic diseases are those diseases that persist for greater than 3 months, 6 months, and even life. Okay, and some of them can be infectious, it could be metabolic, it could be malignancy. Okay, infectious one could be chronic liver disease, maybe hepatitis B, C, or you can have those metabolic ones, that diabetes. You can have also systemic form like hypertension and stroke, which is a complication of some of these diseases. And the topic those diseases we'll be discussing tonight, they exacerbate one another. And as the discussion go on, we get to know how they exacerbate one another and why they come about. Like for example, stroke is a complication of hypertension, and somebody who is a diabetic is also a standard risk of having stroke. And kidney disease can also trigger one of those. So once the disease persists for 3 months and above, you consider it as chronic, unless as acute. So on kidney diseases, we may talk a little bit about acute kidney failure and chronic kidney failure and what to do, what are the causes like the outline talk about. Yeah, so in Liberia, most of the hypertension is on the top of the list. And we now seeing a lot of stroke patients coming and heart failure patient coming, congestive heart failure patient coming. And even before, people used to link most of the diseases on age and other things, but now you see young men, young women developing some of the chronic diseases because of all the risk factors they are involved in, what have you. But some of the diseases, we may not have the diagnostic tool to actually say, yes, the definitive diagnosis and say, yes, this is this. For example, heart diseases like myocardial infarction, acute coronary syndrome, angina pectoral, most often we may not have the diagnosis. But hypertension is a red flag, and stroke is also common in our setting these days. Diabetes is also common, and kidney diseases are also common with a little malignancy or cancer.
Wow. So let me start with you, Abby, and I don't know how you want to go down the list, but whatever you prefer. Let's go down the list to start with the early signs. What caused these things? Why, can they be treated? What are the early signs and symptoms? How can they be treated? Or how can they be prevented? Whatever order you want to go in, and then let's go around the room and talk about them.
I mean, we can talk about diabetes. Diabetes. I'm just going to read it completely. Most of the information I'm getting is from the American Heart Association, from the U.S. Preventive Task Force, and also my own clinical experience and all that. Diabetes is a disease in which the body's ability to produce or respond to hormone.
Abby, hold on. I jumped the gun again. Let's start with our disclaimer. That what we're doing here is purely for information purpose only. It shouldn't and will not, supposed to not replace the advice of your medical doctor. So anything, please talk to your medical doctor, talk to your doctor, not us. We are only providing information. This is purely for information only. Don't treat yourself based on what we're going to say here. Talk to your doctor. Go ahead, Abby, please continue.
Okay, I'll start with diabetes. Diabetes, a disease in which the body's ability to produce or respond to hormone insulin is impaired, resulting in abnormal metabolism and carbohydrates and elevated levels of glucose in the blood and urine. So basically, there are many different types of diabetes, but the three major ones are type 1 diabetes, where you're diagnosed as a child. It usually comes in childhood. Yeah, your body completely does not have any ability to respond to any kind of glucose, and your metabolism level is completely up. The only treatment for that is insulin. That's it. You don't take any pills. You take insulin from the day you're diagnosed. That's why most times when you have children with type 1 diabetes, it's so hard to manage, because as they get older, they don't want to be compliant. They don't want to be sticking themselves and doing all that. But there's so many different technology now where they don't have to stick themselves anymore. So speak to your patients, your child's pediatrician about that. Of course, you're going to be followed also by a pediatric endocrinologist that would be taking care of that. And then the type 2 diabetes is the one you're diagnosed as young adult, older. Most times that is based on your lifestyle, your family history. Doesn't mean that if your family has it that you're going to have it, but their chance is greater that if your family member has it, especially your first degree relatives, like your mom, your dad, your siblings, and sometimes grandparents, the chances are more than likely that you're going to have that. And also, and you're going to continue with that. You start with medications first, based on your doctor's going to decide that. Based on, start medications, and then as you go along, they're going to put you on insulin if they need to. So now, like she was saying before, there are different ways to diagnose diabetes. They do a glucose tolerance test, they do 2 hours test, they do random testing. So if they tell you you don't have diabetes, when they do your hemoglobin A1C, it's also called glycosylated hemoglobin. If you're 5.5 or less, you don't have it. That doesn't mean you should go out and just get all wild about it. You still have to eat healthy and exercise and take, special precautions. 5.6 to 6.4, that's pre-diabetes. So right there, you're entering the danger zone, and most doctors like to start people on medications right away, or they might, based on your risk factors now, like I said, again, your family members and other things that are going on, bees and all that. But also they might say, okay, this is where we are. If you're eating too much of this, or if you're not exercising, or if you're smoking, or if you have high risk factors with your family members, they're going to tell you, go ahead and exercise, do everything that we're telling you to do, and come back. Some doctors will come back within a month or come back within 3 months, and we're going to do it again because something could have been happening that could have precipitated that. But your hemoglobin A1C covers the blood glucose count for a 3-month period. So it's not something that just done random, especially if it's right there, where, like I said, it's like 4 different ways of measuring that. And then when you get to 6.5 or more, you're diabetic. And that's when your doctor, again, some doctors will say, let's just wait a little bit and see if you can control that and come back and we can test it again. Or they might say, let's start your medication right now, because the longer you wait and the numbers start getting higher, if you already have high blood pressure, that's a complication right there. It also starts, like I said, it goes into your urine, it affects your kidneys, and also you start getting aware of the risk factors and all that, the complications, like kidney impairment, your eyes, especially you have to, retinopathy, it's called that retinopathy, your kidney nephrectomy, not even nephrectomy, sorry about that. And so your doctor, like I said, like you also gave you a disclaimer, your doctor, based on everything else, may decide this is what we're going to do to get you back to where you need to be. Now, some people who are pre-diabetic or type 2 diabetic, if they follow all of that, they go back to being the healthy realm. But if you don't, that's when you start leading to other things. So I'll let the doctor pick up from there if you needed to add anything more to it.
Yeah, okay. Thank you very much. Diabetes is actually a metabolic disorder, and it comes about where you have elevated glucose level in the blood. So we'd like to go bit by bit. We'll talk about some of the causes, and we'll talk about symptom diagnostic mechanism, treatment, and how to prevent them. So first of all, insulin can be endogenous. We produce insulin. The pancreas produces insulin. And sometimes we also have synthetic insulin. So insulin regulates the glucose intake in the muscles, the liver, and fat. So we have receptors on the structure. Now, before we go into fine duties and some clients significant, we need to know, because managing diabetes is not only clinician based. Your patient, your client needs to know what he or she has and her own or his own contribution towards his or her own health. So we'd like to know, when do you have a concern about diabetes? Now, causes. We talk about the pancreas. You can have viral causes, infectious causes. You have autoimmune diseases that destroy the pancreas, and specifically the beta cell of the pancreas. So once the body produces hemoglobin that destroys the beta cells, the beta cell will not have the ability to produce insulin. Like we said, insulin regulates the glucose intake. So at the end of the day, glucose will not be absorbed. So besides viruses, autoimmune, you have family risk factor, hereditary. And besides these things, you can also have environmental factor. Now, before we used to call type 1 diabetes juvenile diabetes, but don't be carried about the word juvenile as a childhood diabetes, because these things overlap. You can have somebody, an adult or even an elderly, who can have a form of type 1 diabetes. All right, but the literature says that type 1 diabetes is also called juvenile diabetes. It's also called insulin dependent diabetes. And what are the categories of ages that are of risks of getting this getting the type 1 diabetes? Child up to 30 years. So once you diagnose somebody of diabetes who is 30 years and between 30 years and 1 year, you consider that as what? Type 1. It's just a probability, category of risk factor. Okay, so you consider that as type 1. So in type 1 diabetes, we consider insulin regimen, and we also consider insulin regimen in type 2 depending on complication. So type 2 diabetes can be diagnosed in somebody who is above 30 years, like 30 years and aging adult or elderly. Okay, but you can have symptoms or manifestation of type 1 diabetes in somebody who is at risk of getting type 2 diabetes. Like I said, when you're 30 years and above, you stand a risk of getting type 2 diabetes. So once a diagnosis of diabetes after 30 years of age is most likely type 2 diabetes. Because in medicine, nothing is actually definite. You have the client variation, and sometimes the textbook may not read the patient. Okay? Now, so what are some symptoms, signs, symptoms of diabetes? You have basically the 3 P's. You have polyphagia, which is excessive eating. You always be hungry most often. You have polydipsia, excessive drinking water. Your test will be very hard. And you have polyuria, excessive urination. These are the cardinal 3 things that once a client starts to observe his or herself habit being changed, that the person urinate too much these days, polyuria. The person drink too much these days, polydipsia. The person gets hungry faster these days, polyphagia. These are indicative of diabetes until otherwise ordered. Okay? Now, besides these things, as complications set in, you also have symptoms like tingling, peripheral neuropathy. You have like headache, dizziness, and other things. And those symptoms come with the complication. But these 3 things, the 3 P, excessive drinking, excessive urinating, excessive eating, these are indicative of diabetes. Except where complications setting in, then you can investigate for other things. Now, what are the diagnostic mechanisms for diabetes? How do you diagnose diabetes? Okay, we have the fasting blood sugar, and you have the random blood sugar, which is also called the glucotolerant test. And you also have the hemoglobin A1C. Okay, now, if you have the luxury, you have the facility, you have the diagnostic capability to do all these things, you can do it. But fasting blood sugar and random blood sugar, the random blood sugar is also called the glucotolerant test. They are very, very important. The fasting blood sugar is taken once the patient has not eaten for 8 hours and above. Then you are fasting. So the word fasting is to just deprive yourself of meal for 8 hours and above. All right? Now, and random blood sugar can be taken anytime. Sometimes you even give the person meal, then after 2 hours, take you to the sugar. There are normal ranges for these things. For fasting blood sugar, normally, the normal fasting blood sugar, it should not exceed 126 milligrams per deciliter. So if you do your fasting blood sugar and your fasting blood sugar reads greater than 126 milligrams per deciliter, you are a diabetic. All right? Now, you have pre-diabetes. And the pre-diabetes range is from 100 to 126 milligrams per deciliter. Once you do your fasting blood sugar and you have the 120 milligrams per deciliter, 180 milligrams per deciliter, is why a pre-diabetic state. You need to have the caution. You need to be careful before you progress your diabetic state, a full-blown diabetic state. And for that aspect, you can just monitor your dietary intake, exercise, and other stuff. But for the random blood sugar, to diagnose somebody of diabetes for random blood sugar, the sugar should be above 200 milligrams per deciliter. So somebody eats and you do the random blood sugar after 2 hours, and the reading is 205 milligrams per deciliter. That person is a diabetic. But if you do a random blood sugar and the random blood sugar reads as between 140 and 200 in that range, a random blood sugar between 140 and 200 is a pre-diabetic stage. And in a pre-diabetic stage, you need to be careful. Lifestyle modification, exercise, diet, regulate them before you enter the diabetic stage. But if these things can be regulated, it's a rare flag that you will soon enter the diabetic stage. Now, the hemoglobin A1C is just a test that we normally do to tell you how many glucose is attached to the red blood cell. Over time, a diabetic over time will have the glucose be attached to the red blood cell. So the percentage of glucose attached to the red blood cell will be determined. It will tell you whether the person is a diabetic or not. Ideally, a hemoglobin A1C of 7 and less, you are safe. It's okay. But once it's below 7%, it becomes a problem, meaning you are diabetic. Now,
Doctor, I think we'll bring you back so that you will even demonstrate those tests. But let's go to the treatment, if this can be treated, and then you talk about the prevention. So we get an idea about the science, the testing. Now let's talk treatment and prevention, or how we manage it.
Can I make one comment?
Yeah, sure. Yeah,
I think, and I think we probably should have had it on the list. One of the major factors of diabetes and just about all the diseases that we're naming is obesity. I don't think we've mentioned that, but I mean, maybe later on we're going to mention it. But obesity, basically being overweight, or your BMI, your basic metabolic index is above a certain amount. But I think obesity is one of the major risk factors for all of these diseases that we're talking about. And Abby can go into a little bit more if she has any notes on them.
Yeah, if your BMI is greater than 25, you're already heading towards the obese, clinically obese, because you can look at somebody and you say, usually we just say that person's fat or this person this, but if you do your weight divided by your height and all, you go to your doctor's office, they mind the weight and the height, and they take the division on that. That's your BMI. So if it's greater than 25, it shouldn't be less than 18, because that means you're not healthy or you emaciated. Greater than 25, that's when there's 3 different levels of obesity also. So the obese, clinical obese, and there's the obesity time, 1, obesity 2, and then morbid obese and all that. So yes, obesity is really important. It's one of the main risk factors of getting most of these diseases that we're talking about. And going back to diabetes, one of the main symptoms is no symptoms at all. None. You could be walking around and nothing go on. It's like when you go to your doctors, let's say you go to your doctors and they do your preliminary blood work for your physical. And then that's when one of the doctors call incidental findings, where they'd be like, oh, we did your BMP and all that, and basic metabolic profile. And including your CMP, the complete metabolic profile. And we realized like your hemoglobin A1C is high. That's when usually people are saying, oh my God, I'm diabetic or like pre-diabetic. So most of the symptoms, sometimes everything your doctor explained, and I explained earlier, is one of the main symptoms is no symptoms whatsoever. So you could be, sometimes like I say, you went to the doctor's office or you're in the hospital for some other reason, and then that's when you find out. So it's very important that you eat healthy in the meanwhile and exercise, because, you can find it later on. And sometimes, I have a friend a daughter, she was having some issues, and I also have people who they pass out and they went to the hospital and they found out that the blood sugar was either because you don't want it too low and too high. And that's when they found out that, yes, you are diabetic. So sometimes it's incidental finding based on other symptoms, and sometimes like no symptoms and you have other issues, and then they find out too. So please, please, please. It's always important, as an adult, especially when you leave your pediatrician, because most kids have you go to the pediatrician up to age 18, you can go up to age 26. But usually when you start going to the doctors, they'll do your preliminary testing, and that's when they'll follow you over the years and see where you're going based on your risk factors, your family history, and everything else that we discussed before.
So with this diabetes, can we treat it? How do we prevent it? And how do we manage it?
Dr. Doc want to go first?
No problem.
You go first, and the doctor will buttress.
Okay, I just don't want it to be repetitive. That's all. Well, it can be managed. Like I said before, if you're pre-diabetic, if you type 1 diabetes, you're born with it, so that stays. It just continues until the end of your life. And you also have a higher chance of getting complications early in your life because you've had the injury or endocrine system for the longest time. But for type 2 diabetes, like Eva said, you're pre-diabetic, the doctor can say, guess what? You now have a chance to eat healthy. I think I explained this before. You now had a chance to eat healthy. And like I was talking about, like Liberian food, how we cook. And I was trying to make it, more cultural. And because sometimes when you're talking to an American person talking to a Liberian person about what to eat, they may say something, and the person be like, I don't even eat that, so it doesn't bother me. But what we eat, most of what we eat, our staple is rice. That's filled with carbohydrates, which is also sugar. So, and when we eat rice, it's not like a cute little rice that's on the plate. It's a whole plate. And then we put the soup with it, where I always tell people we put everything on the sea and on the land. We put everything in that soup. I've been to places, before, and you sit there, you're eating pampata rice. You got your pig feet, you got your buni, you got your crab, you got your meat, you got your goat meat. Everything is in there. All of that is high fat.
Hold on, Abby. Why are you picking on palm butter?
It's like any Liberian food, even dry rice. People be like, oh, I got some more dry rice. Yeah, when you go there, you got the pig feet, you got the pork, you got everything in the dry rice. Not pig feet in the dry rice, pork, and then you got your fried fish, and fish is usually fried because we don't steam our fried fish. As fried fish and everything, and then sometimes if you red oil, there's too much stuff. So the carbohydrates, you watch your carbohydrates, you watch your fat intake, you watch, eat less stuff in the food. Try, like I said, more things from the sea and less from the land. So more seafood, and also our seasoning. We have to put salt and chicken soup and all. That's too much salt. You stay away from that. When you watch your salt intake, you take care of that. Watch all of that helps in managing. Based on what your numbers are and your presenting factors, let's say you pass out, you're in the hospital, or your numbers are really high, some doctors will start you right away on medication. But first thing you do is tell you heart healthy diet, heart healthy lifestyle. Like I said, watch your salt intake, watch your sugar intake, drink a lot of fluids, exercise, do all that. And then when you get to the point when, like I said, if they have to repeat your hemoglobin A1C, when you get to that point, your doctor may say, okay, this is where we are. Doctor, nurse practitioner, I'm just going to put that out there because I'm also a graduate student, and nurse practitioner also do all of this. So, they're going to tell you this is where you need to be, and this is what you need to do to prevent that. But when you get to a certain number, that's when, and that doctor might say, okay, this is where we have to start you on the medication. And there are different classes of diabetic medication that are too specific for me to go into right now. So I would just, like I said, based on your allergies, because when your doctor puts you on the medication, is based on your family history, your allergies, your past medical history, your family medical history, and all that. So that's a little more personal, and your doctor, that is between you and your doctor. So heart healthy exercise, heart healthy living, exercising, eating healthy, so you can stay healthy. But when you get to a certain number, they're going to start you on the pills, and then when you get to a certain number over there, they're going to start you on insulin. So the doctor will make that determination based on everything else, taking everything into consideration.
Eva, before the doctor comes in, you have practical experience managing or kind of regulating your diet. Tell me that experience.
Well, like I said, I went to the doctor, and every year, which is advice, Abby and everybody's going to get your yearly physical if you can. You can get physical in Liberia too, or here. Get your yearly physical, which most of them, the doctors will include your simple blood work, like your CBC, and get your glucose and all of that level. So when I went to the doctor 2 years ago, actually, I was a little plump. I'm very short. I'm 5'1", and I weighed almost 190 something pounds. And that's, you know, that's a lot for a person that's 5 feet tall. So he did all my blood work. He called me. He said, you need to regulate what you're doing because, you know, you have a high family history of diabetes. And from what it's looking like, you're pre-diabetic. You're one whatever over for being diabetic. So I decided that it's time for me to cut out a lot of the rice, cut out a lot of the foods. I love to eat. Anybody that knows me knows that. So I had to really change my diet and really change what I had to do. Lucky at the same time, Dwight Forte, he's not here, and Mahmoud, we were talking and they're like, okay, we need to start like a weight loss program. So we started a weight loss challenge called Liberia's Biggest Losers. So each month for 3 months, we get together. There's like a pool, we pay money into it. And if you lose, you determine how much weight you want to lose for a particular week. Most of us do like 1 or 2 pounds a week, which is kind of healthy. You shouldn't lose too much weight, you know, for a given week. So what we do is each month you put in the $5 mandatory. And then if you don't lose your weight, you put in another $5. And what we do with the money is that we donate it to charity. So it goes on for 3 months. And then we have a group where we share ideas. We share what we need to do. I started doing more smoothies. I started eating brown rice. I don't like quinoa or quinoa, whatever you want to call it, but I figured that was a healthier option too. I had to start doing that. You know, like Abby said, more fish, less pig foot. I can't tell the last time I had pig foot. And sometimes even when I cook the food out, like the Liberian food, I try to put less seasoning inside of it. If I do the greens, I try to fry it less, you know, things like that. So from then, it took me about 3 months to get down to like 156, which was kind of like a healthier weight for me. But with coronavirus, I'm going up a little bit, being stuck in the house, but I'm trying to regulate it. But I just know, and one thing I've learned is my body. Learn your body. You know, some of us, there's not one exercise or not one weight loss plan for everybody. Learn your body. I learned that doing, you know, smoothies, detoxing my body, going to the doctors. I don't like exercising, but I know I have to do it. So I found little small exercises that I do here and there to try to keep my weight down. But that's some of the stuff I've been doing.
Good.
Doc, let's conclude on diabetes, and then I hope we can touch on high blood pressure before the program ends.
Okay, so we have already said a lot about the diet, exercise, and what have you. So for the treatment based on medication, you can, for type 1 diabetes, you need to give insulin, okay? You give insulin, and we have different form of insulin. You have the regular insulin, which is short-acting. You have the long-acting, the NPH. So you can give the insulin for type 1 diabetes. Then for type 2 diabetes, you can give oral hypoglycemic agent, the metformin, dining, you can give them. But if a patient comes in complication, the patient is a type 2 diabetic, and the patient came in complication, you need to give regular insulin. Complication like DKA, hyperosmolar non-ketotic state, you can give hypoglycemic agent at that time because the sugar will come very, very high. So you need to give insulin, although this patient has type 2 diabetes, but because of the complication, you need to give insulin to get rid of those T2 and reduce the sugar before you can take them from the insulin to hypoglycemic agent. But you can give insulin for type 1 diabetes. You can give hypoglycemic agent for type 2 diabetes. Sometimes insulin for type 2 diabetes if the patient complication.
So, Doc, here we are in America, we can afford to buy food, and then we can make choice to say, oh, I don't want to eat this one. We're talking Liberia, where in fact, you know, 3 of you joining in that one bowl. You don't have a choice. You can't even pick whatever they cook for you that day. That's what you eat. How are you advising your patient about, you know, exercise, diet, and all that? In fact, I'm hungry and you're telling me about diet. Whatever is before me, I'm going to eat it.
So that's one of the major challenges in managing diabetes in our setting. Like diet, textbook talk about diet, eat this, eat that, eat what a few protein, they talk about percentage. Carbohydrate should be not more than 65%, protein should be around 25, blah, blah, blah. But this patient does not have money to buy all these food you're talking about. So for me, no matter I tell my patients, what you can do, you can eat rice, but don't eat the rice in huge quantity. And if you can do one good thing for yourself, buy your glucometer and make sure you always know your sugar level, because you don't have choice. You don't have money to buy food. But at least with the sugar level, you can say, no, I don't think I will eat rice today, or let me wait a bit. Okay? So we can normally tell them don't eat rice at all. You should look at your client. This client can't afford. Will you tell the patient don't eat rice? Don't eat this? Then how will the person survive? So you can eat the rice in smaller quantity and make sure you do your blood sugar at home and know how it is, and discuss the normal range to you. Anything you come over, and maybe we teach you how to save your own insulin or when to take your medication.
What's about, tell me more about, experience with patient. There is, I don't mean to say that, witchcraft, God, and all the supernatural belief. What is your experience trying to convince people to stay with, treatment plan as regards to say, well, it's either the devil or it's God or it's, some people in my village. How do you culturally, what are the challenges and how you manage it?
Well, for diabetes, I've not had a lot of patients saying that, no, this is the devil, this is from my aunt, this is my uncle, or what have you. They will always accept it and waiting to come for that medication, waiting to change lifestyle. But the challenge is those diet, you tell them the food kind you tell them to eat, they may not afford them. That's a challenge. But I'm not ready a challenge in telling my patient you have diabetes, and they say, no, what diabetes? It can be, what have you. But unlike for other conditions, sometimes they say, no, we got to go to the interior to take help or what have you. So I've not had that problem with any of my patients with diabetes.
Can I just add, diabetes, can you hear me?
Yes.
Okay, diabetes is the #1 cause of non-traumatic amputations of your limbs, meaning those of your legs, because it also affects your circulation in your legs, in your feet. So most people who have diabetes, they have less feeling in their feet. So we also tell patients, make sure you're not walking around without socks on, and preferably if you're walking around the house, make sure you have house slippers on or bedroom slippers or whatever they call it, because you want to make sure that periodically, at least daily, you want to make sure you have a mirror and you hold it under your feet to check to see if there's any sores or any little cuts, because for somebody who doesn't have diabetes, that cut might go away for a little bit, especially like you're cutting your toenails and things like that. And those of you who have diabetes, also make sure you go into somebody who's, trained in cutting toenails the right way, because if you get cut, or even under your feet, if you get a little wound that's supposed to go away over a short period of time, is somebody who doesn't have diabetes, it could, from that little wound, it could get really infected, what we call osteomyelitis. You go to the hospital, they have to do an MRI to confirm that. And before you know it, you end up losing your legs. And most of the time is your legs are supposed to start losing everything else. So you want to make sure you get that check that. Always do not walk around with no shoes on. And if you do see any injury, make sure you call your doctor so they can keep an eye on it. You want to make sure you go to the eye doctor every year, because it also affects the eyes. Like I said, retinopathy, you want to make sure you go into the eye doctor and get your eyes checked. And based on that, your doctor will tell you how often you need to come to get your eyes checked, because you have a higher rate of getting blind. One of the main reasons that people go blind as well. And if you have type 1 diabetes, especially from childhood, you have a higher chance of getting the complications much earlier in life. So you want to make sure. And also they're going to send you also to see a nephrologist, a kidney doctor, because it also affects your kidneys. That's where we run into in complication with kidneys, and people end up on dialysis and things like that. So you want to make sure you follow that. And neuropathy, like I said, that also affects the feet, and also your hands start having tinglings and things like that. You lose the tingling sensation in your hands, and your hands start getting cold. You can regulate your body temperature. So when you see your family doctor, based on where you are in your diabetic stage, your doctor will refer you out to a nephrologist. I see an eye doctor, optometrist or ophthalmologist, the one that does more surgery in the eyes, and also endocrinologist. So all those people will be managing your care. So if they do tell you that you need to go out and see those people, please do, okay? Because it's not like, oh my God, it's sad that, that in Liberia, most of those people are not there, or they're there, but they're not there widely. Like I said, when I was in Liberia, I never went to the doctor. Never. There was not one available for me to go to anyway. And plus, you couldn't afford it. If it wasn't for this nurse that lived in where I live and held, tended the entire estate, I wouldn't be where I am today. So yay, nurses. But, but like I said, those are the complications, and you want to make sure a little wound in your foot can cause you to lose your entire leg. And when you lose your leg, that's your life or your livelihood, because that infection travels up. I've seen people who have diabetes that have lost like both limbs, and that infection travels up. And for you men, circulation. The most important thing to men, well, maybe not all men, but if you cannot perform in the bedroom, that's like a big, red flag right there. That affects relationships. So please make sure that you are getting tested and making sure you follow up everything that your doctor is telling you.
What diabetes got to do with performance, Abby?
Well, if you have poor circulation and your heart is not pumping out the blood like you're supposed to, it's not going to pump the heart out to your organ, your male organ, or so if you can't, and sometimes it's like it goes from length of time that it can stay erected, or sometimes nothing, and you can go there medications to help it. But there are times where if the circulation is very poor, and remember, you can't use certain medications if your heart is not pumping out all the time. You see those commercials on TV. So just make sure you're taking the time to, like I said, follow your doctor's instructions and try to be compliant. It's very hard. Diabetes is not an easy disease to have. So you want to make sure that you follow your doctor's instructions so you can stay healthy and delay the complications as much as possible.
Thank you. And let me ask a question and then read some questions on Facebook. So please listen, and Dr. Mianyen, you can go first on this one. Number one, is glaucoma related to diabetes? Number two, what does exercising have to do with diabetes? You exercise, to get rid of what? Is it the sweat or the weight? And Conan Hall said, great knowledge. Thanks for the information. I lost a cousin 2 years ago to diabetes, and it really opened my eyes on how deadly this illness is. Thank you so much. So Musu Stewart was the one who asked, is glaucoma related to diabetes? And again, let's go back, give more explanation on how this is related to your eyesight.
Okay. I can come here, right? In fact, especially for type 1 diabetes, once somebody is diagnosed of type 1 diabetes, you have already had problem with your eye. Because the complication of diabetes, you have the smaller vessels, which is the macrovascular complication. You have the bigger vessel complication, where one of the panelists talk about diabetic fold and other things. These are things that will come in late. But the number one thing that you should routinely test your patient for, once the patient has been diagnosed of diabetes, this patient should go to an ophthalmologist to ensure that your retina has not been injured. Because, mind you, we're talking about sugar accumulating in blood. You have more sugar piling up in blood vessels. So the tiny vessels will be involved first before you can talk about the bigger vessel. So yes, diabetes is one of the major risk factors for eye problem, glaucoma. Sure. So to exercise, most of things, like the obese patients who are obese, because obesity itself is a risk factor for type 2 diabetes. So once you are obese, you exercise to burn the fats, the protein, and those non-glucose glucose sources. Now, so if you exercise, you break more fats, you break more protein down. Because if you don't do them, once you get hungry, the liver will start to produce more glucose through gluconeogenesis, glycolysis, lipolysis, then at the end of the day, you have more glucose in circulation because of your body mass. So that's one of the benefits for exercise, for obesity, patients who are obese. Okay? It will encourage, it will prevent you getting diabetes because of the rates of being obese.
Another question from Kona Hall. When you are pre-diabetic during pregnancy, does this put you at risk? Let's talk about diabetes and pregnancy.
Oh, yeah, the third one I mentioned, didn't mention gestational diabetes. Yes, most people, when you do, they will run the risk of becoming, gestational diabetic. But if it's managed well, you could recover completely after you have the baby, but you do have a higher chance of developing it later as a regular type 2 diabetic. So you have to make sure once you have that baby, you get past the lactation stage and all, you're eating healthy. And remember now, everything goes back also to your family history and everything else. But you could have no family history of diabetes as well. But you do have a higher chance of developing it later on in life. So they tell you after you have the baby, make sure you're watching that. And people who have gestational diabetes, there's a higher risk of having a stillborn birth as well, or a baby that's really large that may have other complications. Or you could run, and also another factor, a lot of yeast infections too. That's one other signs of diabetes. So if you have constant yeast infection, that's another sign of diabetes too. So, but like you said, gestational diabetes, you can recover from it after the pregnancy, but you do have a higher chance of developing type 2 diabetes later on in life, depending on how late you have your pregnancy and all.
Let's go to hypertension. And ladies and gentlemen, if you are just joining us, this is Focus on Liberia. We are discussing chronic diseases, and we've just discussed diabetes. We're going to go more into it, but we want to touch, and we're almost out of time because there's so much. Remember, this health talk was planned for a series, but because of the coronavirus, so we took 2 of those Sundays to talk about coronavirus. So we are kind of crunching this into one night, which is very, very challenging for these panelists to do. So let's touch on high blood pressure before we can. Let's talk on high blood pressure before we can close this. So I will start with Eva. Eva is non-clinician, but she got experience. Eva, share your experience before even our clinicians come in.
Well, I don't have any personal experience with high blood pressure, but my family, just about everybody in my family has, high blood pressure. And a lot of them are on medication for it, and they have, other complications. I've had family members who've had stroke due to high blood pressure. If you don't control your blood pressure, you're at risk of heart disease, you're at risk of stroke. So get it tested regularly, or you can even go to, I know in Liberia, they don't have places you can go and get it tested, but here you can go to to the pharmacy, you can check your blood pressure. And sometimes even checking your blood pressure will not mean that you have it, but at least if you check it and it's above a certain level, you're able to go and get it, go to your medical doctor.
High blood pressure is a state of elevated blood pressure over a period of time. Right now, the American Heart Association wants your blood pressure to be 120/80. That's where they lower the rate. It used to be like 130/70 or 140/80. They lower the rate and so it's 120/80. Now, if you went to your doctors or you were over at a hospital, and most of the time it's also like an incidental findings, they will test your blood pressure. If they find it to be a little high, once again, they go back to saying again, your risk factors, your like people are most high risk of getting high blood pressure, which is also called hypertension. So they're going to take your blood pressure the first time because you go to the doctor's office. We take your blood pressure at the beginning. The medical system will take your blood pressure, your vital signs, and everything. Usually, if it's high, we'll do it again like at the end of the visit, because when you come in, you're already nervous. So we'll see what it is. If your blood pressure is high, your doctor will probably bring you in the next week, or let's say over a period of 3 months, but 3 trials of the blood pressure. If it remains high, Your doctor is going to start with a heart healthy diet. Everything we talked about diabetes, because they all kind of interrelated. They're going to start with that. And then based on what it is, if it starts getting higher, like I said, if it's to where they find it's too dangerously high, they may have to send you to the emergency room anyways, if it's too dangerously high, or to start you on medication. And again, there are different types of high blood pressure medicine based on what caused your blood pressure and based on other presenting symptoms. So when I see people on Facebook saying, my doctor ordered this, this other person saying, my doctor ordered this, there are different reasons, or the reason why the doctors order different kind of blood pressure medicine. Now, there are signs and symptoms of high blood pressure. One, most important, none. Most people don't know they have high blood pressure until they come into the hospital or go to the doctor's office and they find out that they have high blood pressure or they start having symptoms. But some of the symptoms, persistent headache, what is really dull, persistent headache. If it's very sharp, then there's something going on there. You want to go to the emergency room. Dizziness, shortness of breath, nosebleed. And once again, like I said, no symptoms. You know, some people also add, if you've been laying around, you're exhausted because your body's working so hard to get that blood pressure down. So you want to make sure your risk factors, race, like I said, African-American / Black, your history, your obesity, and other illnesses like, diabetes and everything else. So you want to make sure, to diagnose it, like I said, based on your symptoms and thorough exam when you go to your doctor's office, or incidental finding when you were in the hospital and they're doing other blood testing and they find out, most of the times I'll ask the patient, I'm like, did you know you have high blood pressure? Oh, no, my brother, my sister, this person. And that's when we go into the whole medical interview saying who has high blood pressure in your family, your mother, your sister, your father, like I said, your first degree relatives, and then we go on from there. There are many specific things that we do to diagnose patients. So that's my thing when it comes to social media. People say one thing and then they convince people don't take your medicine based on that. Please, whatever's going on, there's a relationship between you and your doctor. Yes, we want you to come in with some knowledge base. Yes, we want you to come and say, but don't say, I went on Google and this is this, because your relationship with your doctor and your medical history is all personal. We're looking at much more than what it says on Google, and it's to you, individualized to you. So the doctor will continue from there.
And Doc, what I want you to put emphasis on is the treatment, the medication, because I have heard complaints that some of the medication will affect how you perform in the bedroom, and so and that's because it's kind of a little personal to me, because I have a friend who was not taking his medication because he said he doesn't want that to affect him in the bedroom. So that was a big deal. So, and then how that relates to a stroke, I know you touched on that earlier. So as you buttress that, please add those two.
Okay, so let me just add those two before I just go through it. What really happened about sexual activity, I don't know of any medication that has any major side effect with potency. But you have hypertensive nephropathy and neuropathy. So the nervous system is responsible for erection, is also responsible for ejaculation. So hypertension is also affects the nervous system. So for diabetes, hypertensive neuropathy, once you progress with that hypertensive neuropathy, you may have complication of such. Now, for hypertension, let me just clarify a few things about what you need to know about the range. Okay, we have an average, and we also have range. Okay, so hypertension itself is persistent elevated blood pressure above the normal. So we have, most often, those of you who have been going to the hospital, you always hear saying days over days. You have the numerator and the denominator. So we have the systolic and the diastolic. The normal range for the systolic pressure that physiologically your body will work in normal circumstances is from 90 to 139 millimeter mercury. All right. Now, anything above 139, like 140 and above, is a systolic hypertension. For diastolic, the normal range for diastolic is 60 to 89 millimeter mercury. So people, you and I may have the same pressure, but once your diastolic falls within 60 and 89, it's considered normal. Once the systolic falls between 90 to 139, is considered normal. But you can also have high normal. In the case of the systolic between 130 to 139, you are not a hypertensive patient, but you need to be careful. It's a high number. And the same with diastolic. Once the diastolic is reached around 90 to 99, you need to be careful. It's high number. All right? I mean 80 to 89 is high number. Now, so once your systolic is above 140, your diastolic above 190 is hypertension. So you can have isolated hypertension like that, diastolic hypertension, and you can have a systolic hypertension, meaning your systolic is high, or your diastolic is high, or you can have both of them happening. So you have a risk factor. You have essential hypertension, which is also called primary hypertension. Then you have secondary hypertension, which can be due to an underlying pathology like diabetes. All right? Diabetes itself is a risk factor for what? Hypertension. Chronic kidney disease is a risk factor for hypertension. Okay? For the primary hypertension, you have family history and you have food. Okay? For that, you just need to modify your lifestyle where you eat a lot of salt, reduce the salt intake. We're not telling you to stop eating salt, but you need to reduce the salt intake. And also, lipid, your fat. You got to avoid eating a lot of saturated fat. Okay? That alone can also cause a lot of deposition in your blood that will increase the pressure there. Okay? For secondary hypertension, like I said, diabetes, chronic renal failure. Once you got chronic renal failure, you will develop pressure. Okay? And also, dyslipidemia. These are some of the things that can cause hypertension. Symptoms, you talk about the symptom, yes, headache. And besides the severe headache, you can also have symptoms based on the complication. Numbness, okay, hypertensive neuropathy. You also have hypertension itself can also cause renal failure. In that case, you may be having oliguria or anuria, what have you, hypertensive nephropathy. Hypertension itself can also affect the eye. You have hypertensive retinopathy. Okay, hypertension itself can also affect the brain. Okay, stroke. So if you have hypertension and the pressure goes very high, especially in like the old test used to call it malignant hypertension, or in the case of hypertensive urgency, where you have pressure very high with end organ damage. So in that case, you can have stroke. And if the stroke is due to pressure, most likely it might be due to the stroke. Most likely, but only CT will tell you. The definitive diagnosis is the CT. But then when a patient comes to you and the pressure is highly high, alarmingly high, where maybe the systolic is above 180 and above, okay, pressure of such can rupture the end artery, and that person can experience hemorrhagic stroke. But these are other cardinal things in the patient history and in physical exam that you would blend together to say, I think this stroke is hemorrhagic stroke or ischemic. But all in all, you need to do your CT or MRI to know whether it's actually hemorrhagic or ischemic, because it will also help you with your management plan. The way you manage hemorrhagic stroke is different from ischemic stroke. Now, pressure can also cause renal failure. Okay? Yeah.
Okay, let's talk about the treatment, because the question I was asking there is there are a lot of medication people give to this patient when they have hypertension, and I don't know what that based on. You know, is it because is the one available? So what are the different medication, and why will you give patient A this medication as opposed to another medication for this patient?
Okay, so we have classes of antihypertensive regimen. You have like the calcium channel blocker. Some of them work directly on the calcium channel, okay, at the level they had the neuromuscular area. You have the beta blocker. You have the ACE inhibitor, the angiotensin converting enzyme inhibitor, like the captopril. Beta blocker can be like the atenolol, okay? And you can also have diuretics, the hydrochlorothiazide, spironolactone. You can have like the ARB, the angiotensin receptor.
When you say these are beta blocker on this thing, what does that mean?
So the beta blocker, these are medication you use to work at the receptor level. In the vessels and in the heart, you have the alpha receptors, you have the beta receptors. So the beta blockers, the atenolol, when you give beta blocker to a patient, it will bound to the beta receptor, thus inhibiting or preventing or stopping the effect of the beta receptor once activated. What the beta receptor does, the beta receptor, once it's activated, it increases the heart rate. Okay, and arrhythmia too can also cause heart failure, hypertension. So increased heart rate can also cause pressure. So if the pressure is due to like tachycardia and arrhythmia, what have you, beta blocker will be very good. It will be acute for that because the medication will block the receptor so that those trigger mechanisms, substances are causing the beta blocker to be activated, so the heart rate can increase. It will be prevented. Then calcium channel blocker is like nifedipine, is one of the calcium channel blocker. That one works directly at the level of the heart because calcium itself is a substance that is needed for contractility, for the heart to contract. And that one is more of pathophysiology. You got to understand why the heart need to contract, why the heart got to beat, because the heart rate and the heart contraction, all these things contribute towards pressure, cardiac output, and what else. We don't leave that one, actually clinical. Yeah. Then we also have the ACE inhibitor, ACER, angiotensin converting enzyme inhibitor. That one, it works at the level of the kidney. All right, it works at the level of the kidney. It's also important. And we have the diuretics, the furosemide, spironolactone, hydrochlorothiazide. They also work at the level of the kidney. Okay. Now, but if this patient is a hypertensive patient and the patient does not have any coexisting comorbidity, because you can have hypertension, like we said, these things actually trigger one another. If you are hypertensive and also a diabetic, you got pressure and you have diabetes, you go for ACE inhibitor, the captopril. It will work well for you. It will work well for you. Okay.
So before I go to the other panelists, there's a question here from Musu. And most of the questions based on what's going on in Liberia. So, are there vigorous public awareness programs in Liberia for diabetes and high blood pressure? Because these things are very, very important. Like the one you're saying now is like, oh, wow, we are in America and some of us don't even know this. What's about, my people there in Yawuri Mesran or in Feasible? So what programs are there to for public awareness about these chronic diseases, especially diabetes and pressure that are very common?
Yeah, we do have programs, radio talk show, Ministry of Health, educating people about diabetes and hypertension. But is the program being there is one thing, and the persistency of the program is another thing. But people, there are a lot of groupings that ensure that messages of pressure, diabetes, people should know about these things. And sometimes people are even on the street taking people regular pressure, although sometimes they do that to get a little money. But I do know that we have massive awareness on these things. But the awareness is one thing, and adherence is another thing.
Abby, you carry on awareness program on your own live show. And what is the how receptive are your audience to a program like that, and what do you think can be done to kind of extend such education to Liberia?
They're very receptive. Unfortunately, I don't get on there as often as I used to because of school and all. But people are very receptive, and also they also like inbox me and ask me different questions like specific to them, because I always tell them, what your relationship you have with your doctor is totally different. So I have to know too much more about you for me to say this is what they need to be doing. This is what so I do give them general information, and I do explain certain medications when they ask me, or if they ask me about the family members. And like I always tell people, all the diseases that we have, somebody might say, oh, I don't have any of that. But I say, at least 2 or 3 people who have diabetes, high blood pressure, or who has had a stroke, or who is at a high risk for a stroke. So, and I say at least 2 of those 3 people, even 3 of the 5 people you know are related to you, your first degree relatives or second degree relatives and all that too. So that puts you right there. That makes you a high risk. So when I say things like that, people like I was talking to the other guy the other day, and he goes, yeah, you know, if you put it that way, yeah, I guess this person had that person had this, and this person had that. So when you go to the doctor's office, and I just say, oh yes, because you did so, this is that. No, when we get your medical history and all, we'll say, okay, yeah, that puts you in a higher risk. So people are more receptive. And also when I do my annual health fair, I do blood pressure. I go over more of the things with more people, and I give information. So I tell them, go see this doctor. There, one time I was doing somebody blood pressure. We're having a good time. I said, you need to leave now and go to the emergency room. Your blood pressure is very, very high. Go to the emergency room, because I have to tell people that, whatever's going on, stop what you're doing. I know we're having fun. I know this is we're having a nice little time here, but please leave now and go to your doctor. So like the doctor said, their range of blood pressure and all that, but the normal blood pressure, 120, 80 and below. It can be too low and it can be too high, and we also, the American Heart Association, the U.S. Preventive Attack, so they come out with new different recommendations yearly. Sometimes it's biannual or every other year. So we who practice in America, we have to follow that. So I don't know what they do in Liberia and all that. I don't know if they have I don't know. So I'm just going to leave that out there. So what I'm telling you is the most updated information, because by law, we have to follow that in order to conduct our practices. So yeah, people are very receptive. And there are other Liberian Health Forum on TV, on Facebook too. So people follow that as well. So because people were really receptive of doing stuff, but it's just that one thing about Liberian people at the same time, don't tell me what to eat, don't tell me what to do. It's like, no, I'm not telling you what to do. I'm just putting it out there, and you can follow it. It's up to you. Nobody's forced to tell to do what I'm telling you to do. But people are mostly receptive to what we talk about.
So Ivo, I know you're not a clinician, but you work in the hospital. Just like as long as people see you entering that hospital, family members, other people, they ask you health-related questions, I guess, because they do that to, if you do anything related to IT, they want you to do their website, they want you to protect their network, they want you to program for them. So what feedback are you getting from people health-wise? Do they ask you for treatment? Do they ask you questions relating to health? And then you have a program of Liberia Biggest Loser, you said? Yes. Yeah, and so I know that what is the awareness on that level, or what's the involvement of people in our community doing things like that, even beyond weight loss?
Well, we have the Liberians Biggest Losers. I mean, it's a right now everybody wanted to make it a private group, because every week when you do your weight, you post it. We post it out there. I mean, it's nothing to be ashamed of your weight. When I look at you, I can tell, okay, you don't weigh 120 pounds. We are what we weigh. We are what we are. So we try to make it very open for you to come out there and let people know, be aware. One time we even had somebody participating in Liberia. He's a young man in his 30s, and he had diabetes. He was just diagnosed with diabetes. And he came on, learned some things, went to his doctor. He's got his diabetes under control now. And I think at first the doctor had put him on medication, but eventually as he was doing the program and stuff like that, he got off of his medication due to the exercising and changing what he was eating and what he was doing. And at work, I get calls from patients. I deal with a lot of the patients. And like Abby and the doctor said, a lot of these diseases, people think it's for older people. But I see so many young people that have diabetes and high blood pressure. And a lot of it is due to them being obese. And I wish Ketrick would have made it here tonight. He works at a physical therapy place in Liberia, rehabilitation place in Liberia called SALT. And when I went back home, I had a store that back there that we kind of focus on more healthy eating. And I kind of partner with him. I would bring brown rice and stuff into the country, and stuff that had less salt and things like that, to help to educate the people that came in. And we sold it to them at an affordable price. And we told them, okay, you can't find brown rice, try to eat buckwheat. So I kind of work with him also to try to see what we can do, especially they were getting young children over there, 25, 30, that came in with stroke, that came in with, diabetes and things like that. And one of our main things is the rice. Rice is our problem. And we need to figure out how we can regulate that and eat more complex carbohydrates. And one of them, and even for me personally, I've noticed that when I eat white rice, especially now that my body, I kind of detox from eating it, I notice a big difference when I even try to eat it again. My body's like, no way, stop it, don't do this to me. So when I eat the brown rice, I notice, it's less carbs and things like that. It's a little bit better for me, but that white rice is our problem.
I don't know if we cover it, is the cause of hypertension. And most of the time they say, oh, because you are worrying about something, or, you went through divorce, or your boyfriend left you, or something like that. So is high blood pressure the result of somebody worrying about something? Doc?
Sure. Stress is one of the risk factors for high blood pressure. Sure.
Well, stress definitely. Sorry, go ahead.
Yeah. The reason to that is that once you are stressed out, the body itself will have allowed the adrenal gland to release more cortisol and stress hormones that will have some effect on the heart to make the heart to beat fast. And the more predisposition you have in stress environment or stress partner or stressful situation over a time, with this impact it has on the heart, you eventually develop pressure.
All right, laburo and rice. And I think we're very proud of this. Oh, don't eat laburo, don't play with our rice business. We killed the president because of rice, and we did this with rice and everything. And I think there is a rice economics, because anytime rice price go up or down, then there is chaos. What else can we eat to help us besides rice? Abby, let me start with you.
Well, like Eva said, you want to start off first with eating brown rice. If you can, I know some people add like a little bit of oatmeal to it because oatmeal has fiber in it. So it kind of helps the rice leave your body faster, because you always want a thick thing high in fiber that's going to help whatever you're eating release out of your body. I know some people who eat rice for breakfast, lunch, and dinner. That is not a good idea. Increase your fruits and vegetable. Eat your rice. Like, it's not going to happen, just because the doctor tells you that you have a high risk of diabetes or your blood pressure is high. It's going to take time. Start decreasing. If you take the 3 tablespoons of rice, start decreasing it little by little. Try to cook a little less every time. So that way, if it's not there, because once you're eating and you have to go back and there's still more rice in the pot, you're still going to go back to it. So start practicing eating a little less, add more, have some salad, have a fruit or something before you eat your rice. So at least that way your stomach is already full before you start eating the rice. Drink at least a whole glass of water. That fills you up right away too. So you're not leaving enough room in your stomach to put all that rice in. And like I said, it's not just the rice, you want to also make sure whatever soup you're cooking with the rice, you want to watch what you're adding to that, because all of that plays a part.
Let me add to that. So what's about the fufu and the plantain and the cassava and the gari? Because I'm not eating rice, but I want EGB.
That's also carbohydrates, because people would sit there, and I think I wrote a post a couple of weeks ago or a month ago where I said if you eat a whole bowl of pepper soup and and fufu and all that, that should be followed with dessert. Shouldn't be followed with a bowl of rice. Because people think, oh yeah, I had my fufu and I had my GB, or I had dumbo, whatever little stew thing, whatever concoction, I can follow that with rice. It's not really eating. That's just appetizer. A big bowl of fufu and soup, that's not an appetizer. That's a whole entree right there. So you want to make sure at least you have some salad before, or let's say fruits and vegetables. Drink a lot of water, and then you have your fufu and soup, and then you follow with dessert. Not a bowl of rice. But if you are tempted to have more rice with it, have like a little bit of rice, because your stomach's already full. Or just walk away from the table. Walk away from the table. Do some other stuff. Or like if you're at a party, you eat the food, you have the fufu and soup, get up, go do some stuff, get some dancing on, you're breaking down all that fat right away, and getting the weight off. And then you have a little bit of rice to go over it. And don't eat too late, because when you eat late and you go to bed, at least don't eat like 2 hours before going to bed. If you go to bed right after you eat, or you go lay down right after you eat, your body's just storing all that fat and it's adding on to everything else that's going on into your body. So try to cut back on the rice, take a little bit of time, brown rice, add some oatmeal to your rice, and just drink a lot of water, fill yourself up before you eat that rice, so that way you won't leave too much space in your stomach to eat the rice.
Dr. Mianyen, you work in Saklapi. You don't go to Saklapi and where they say Gengba gave you energy and you talk about don't eat GB. I don't think you want to stay there.
Sure. Yeah, so we got a lot of food kind. We have the yam, your edibles, fruits. You can eat these things. And we got them in Liberia. I don't know where they got the mentality of once a Liberian man doesn't eat rice, like you've eaten nothing. We got all this stuff around here to eat. So we encourage them to eat them. But the encouragement is one thing, and also going home and eating your yam and edibles is another thing. That's the challenge.
That was too ambitious to kind of take up more, but I'm glad we talked too a little bit, and there will be room for more. We are here at Focus on Liberia. Our goal here is to educate, elevate, and promote all things Liberia. So the best we can, we try to have this kind of program. We'll be glad to have you back when I think the viewers love this, and we're going to have more of this. I can't thank you enough for coming to be part of this thing. So let's go around the room, starting with Eva, Abby, and then Dr. Mianyen to give your final thoughts.
My final thought is that we have to start thinking about our health more, especially we as, I will put it at Africans and even the African Americans here in the US, think more about your health. That bowl of rice tastes really good, but especially for me, I've had to learn portion control. And one of the main things that I've learned is to detox my body after I've eaten all of these wonderful things. There's smoothies, and then there's naturals way out there that detox your body sometimes, or we should have regular bowel movements basically. And you can also detox your kidney. Use like lemon water, things like that with mint, or sometimes I put pineapple in it just to help to clean out your kidneys and clean out your bowels, because you can eat something, it can stay in your bowels for months, at a time. And if you don't clean out your system, especially with our fufu, it go down there, it will stick to your intestines and all of that. If you don't clean it out, then you start feeling weighed down, you start feeling bogged down, you start feeling tired, and you wonder why you're fatigued and tired all the time. You probably need to clean out your system. So it's just a learning thing, and find a partner, somebody that you can work with that can be accountable, help you lose that weight, help you get that diabetes under control, help you, because a lot of it comes with anxiety and being anxious. But if you find somebody that can help you to lose that weight and make you accountable, I think that's great for us. We have to start talking more about our health. Know your family history, because a lot of us don't know our family history. We go to the doctor, oh, my so-and-so did not have this, or oh, my so-and-so don't have this, or not knowing your mom died of diabetes, your pa died of diabetes, but you don't know because we don't talk about our family history. So that's the main thing I tell people also, know your family history. And Dennis, thank you for being here. I hope this is our first show of many, because this topic is very important. And thank you for having me on.
Thank you.
My closing thing, like she already Eva touched on, know your family history. Right now, a lot of people are quarantined at home, so it's the best time to call your family and talk to your mom or your dad if they're still alive. Sisters, say, by the way, I just called to find out who had high blood pressure in the family. And most Liberian people say, oh, that person had pressure, that person had pressure. So right away, you know that somebody close to you had blood pressure in the family. Who had diabetes? You also want to ask them, because we always ask you to, okay, this person had high blood pressure in your family. When were they diagnosed? Because you want to also know, okay, my mother had high blood pressure. She was diagnosed at this time, because that depends on what time you were diagnosed. You want to, like I said, delay the complications or prevent it as much as possible. You want to also want to find out who died in your family. What did it die from? Was it a sudden death? Did the person complain of anything with the heart and all that too that caused a sudden death? Because once you have issues like that, you go to the hospital and you say, oh yeah, my father died. Suddenly he was having chest pain. He was just going on and he just died. Or nothing was going on and he just died. Sudden death is also very important. We add that into your family history when we talk about that. And then your own history. You want to go back. Look back and see, okay, ask your family again, your mother, your father, say, when I was sick, when I was smaller, what diseases did I have? What diseases did my brother and sister have when they were growing up? And you want to add on that. Always have that with you somewhere. So when you do go to the doctors and they ask you those questions, you're not saying anything because we're writing everything down that you're telling us. You know, we will not be writing it down right in front of you, but we do write that one, because when we do the treatment plan, that's according to what everything else, we're taking all that into account, because when you go back and say, wait a second, you know, this doctor or this person didn't treat me or didn't give me the right treatment, we pull that up. So when we go to court, we pull that up and it's right there. So you want to make sure, but that taking the legal part out of it, but that's just as important. You want to make sure you have none of that. So we do that also in order to teach you, because most of what we do is teaching. Nurses, doctors, nurse practitioners, most of what we do is teaching, and we also document what we teach you. So know your family history, know your own history, know your sisters and brothers' history. And they may not want to tell you because some people want to be private, you know, but just tell me, if you don't want to tell me, I understand that, but I just want to know so I can take care of myself. And also tell your brothers and sisters the same thing too, because they might be going through something that you don't know. But like you said, you know, we have much more to discuss maybe on a later show, because you know, it's very important for our people to start thinking that health. That's one of the main reasons why I started my forum as well. So people are hungry for health material out there, and personally from a cultural perspective too, because sometimes, like I said, you can be talking to a practitioner who can say something that you may not be able to relate to, but somebody who can say, okay, I'm a Liberian person, can tell you this. You say, oh, okay, well, I know I'm not supposed to eat pan butter late at night. I'm not supposed to be eating this. So they put in the cultural level that you understand it. So. But I hope to see you guys again. And Doc, thanks. Nice meeting you. And Eva, you know, I'll try to look up your group. I've been doing my exercise, but because of school and work, it's kind of hard, but I'm hanging in there.
Yes.
Right. And for those, sometimes we think we are skinny and we don't do exercise. But when the rain is coming, just the little step you take, you'll be breathing like that. And so these things are not about size or being overweight or anything like that, or age. Not right. And then with the palm butter, and look at, you know, I come from a palm butter country. But I was in Ghana also. I never saw them cooking palm butter, but they are the one that are selling palm butter to us, to America. So I'm like, what's going on here? Palm butter is supposed to come from southeastern Liberia and be shipped here. Why they are shipping palm butter from Ghana? So somebody told me that is a big red flag for cholesterol. Or that oil blocking your... So there's a much more call. It said we need this information in our community and please come back. And then there is a slide here. We want to focus on Liberia. We want to have a continual program on health. And so it's something that we are working on. We are talking to some health practitioners to come and do the show right here on Focus on Liberia. This is part of what we do, to educate, to elevate, and promote. So please, if you're out there and you are interested, you can talk to me, talk to Abby, talk to Eva, or talk to Dr. Mianyen. And we're forming this team now. Our goal here is for Focus on Liberia to become like CNN, where you can come here and do your show. You know, it's like a mall. Whatever you are selling, come and sell it here. And we'll be glad to partner with you, to collaborate with you, so that our people get the right kind of information that they need. Let me go to Dr. Zico Mianyen joining us from the nation's capital for his final word. And Dr. Zico, we want you back as often as we can. We want to see what's going on there, what doctors are doing, how, you know, we can all network. We have other practitioners here that we can all be part of the same happy family, so that we can compare notes and be able to work together. There are a lot of, we all work in silos. You right now, on top of my head, you can name 10 different groups or individuals that go to Liberia every now and then for health-related programs. But if we can all pull it together, if we can all work together, as one big group. But because these silos is an example, we call that system thinking. Everybody, we're working on the same body, but different people. So the foot doctor doesn't talk to the stomach doctor, and the head doctor doesn't talk to the pregnant, all that. So as we all work on Liberia, this one body, it's better that we talk to each other and work together as a group. That will help. So let me come to you, Dr. Mianyen, for your final words, and tell us when you're going to be back again.
Okay. For the audience, if you can't carry anything home tonight, carry these few words. Hypertension, if you have pressure, you are playing with fire. You are playing with a dirty weapon, and you need to be very careful. Take your blood pressure on a daily basis once you have hypertension. It kills before your family know that you are dead. And if you have hypertension and diabetes coexisting, you're in trouble. You're in a big, big trouble. Because once you don't stick to your rules, you don't monitor your blood pressure, you don't monitor your sugar, you're in trouble. And that trouble may lead to your death. And another thing, young people, alcohol. We love alcohol, we drink alcohol, but alcohol is also very dirty. Alcohol contributes to these things. And both of them can trigger one another. So you need to be careful. Take the message home. Even those of us who are not hypertensive, make sure and do your routine BP. You can buy your own BP cup and take your routine BP every day. You can't tell. Okay? So I'll be available anytime. Just let us be in touch. Let me know anytime you want me to come or participate as a panelist. If I will not have a tight schedule, I'll be available. But I'll be available most often.
There's a comment here. They say we don't like to hear from engineers, but that's not true. We like to hear from engineers. We had a show here on two civil engineers discuss our Liberian roles, and we also want to do a lot, but we can do it all. We need help. We all have our 9-to-5 jobs, and this is extra. So whatever you can do, you can run things by us. We don't have all the ideas. You can inbox us on what you want to see on Focus on Liberia. Talk to us about show ideas, and we will definitely find a guest. Liberians are just incredible, smart, and professional people. Any works of life, any professional background you think of, we have them. Even if we don't have them, we can go outside. So please feel free to send us your comments, give us feedback, and how we can improve the program and how you can help us. This is very very intensive. We're putting a lot of work to bring programs like this to you. Before you see the people up here tonight, we have to coordinate with them. We have to test how we can come on this show and give you the best we have. We need to find the best people, work with them so that they find time out of their busy schedule. So it's a lot of work, and we need your help. We need help in different forms, and so please be there for us, and we can help to make Liberia that land of liberty that we all want. I want to thank those who are giving comments. Health practitioner, if you have time, please go back to those comments and respond to them. They will keep asking questions. This video will be available on Facebook or on YouTube. You can still go there and watch it, share the video, subscribe to our YouTube channel, and let's help make Liberia that great and sweet land of liberty up to be disease-free. When we are healthy, we can do a lot of things. COVID-19, we all scared, we're home and all that, but we can still educate, we can still do things. While we are all quarantined at home, that's the time we eat a lot. I mean, the snacks used to take maybe like a week. Now 2 days, all snacks gone. You have to go back. So, and we are here home eating and probably getting fat. So, a lot of things we do. A program like this go a long way to help all of us. Once again, I say thank you, and at this time I will say good night and God bless you.
Thank you.
Good night, everybody.
Ya la vida is our